they have their benefit is when you're treating a really resistant lesion and you can't get it to open. So they work. They help us technically to get a better result. So if a high pressure balloon doesn't work, we use a cutting balloon. This is an example of using a cutting balloon next to another balloon, and it was claimed to be a great way to do this. I'm not sure that this wouldn't have a much higher incidence of rupture if it was used on a regular basis, because you're putting an extreme pressure on one side of the vein in one little spot with a cutting balloon relative to the rest of the vein. So does it work? Yeah, it could work. Is it proven? We don't know. I think it's a reasonable thing to try. So this is some of the examples of what I've seen on the web now. Blank Health Systems performed the first CCI procedure using a cutting balloon. That just went up last month. I used one of those 9 months ago on a CCSVI case. They don't tell you that the restenosis rate is the same. We always use high pressure balloons and achieve a 99% success rate, but on the same website it says we routinely use stents. So what are you routinely using stents for if you get 99% success rates with high pressure balloons? Dr. Y can almost recanalize your occluded stent using a radio frequency wire. The only one I know of, he failed on. Dr. Z has zero restenosis. Anybody says they have zero restenosis, run the other direction, okay? So I think I just needed to do this as sort of, I believe in this procedure. I believe that there's something going on here. But I also believe that it's getting commercialized very rapidly around the world. As Justin said, there are 40 sites doing this. And I think you need to be treated on protocols with people trying to collect data, with people who are going to sit down and have an honest conversation with you about things that they know they don't know. And I think that's really important. What about stents? Well, I think Justin covered that. I'm going to sort of just skip over that to keep things moving. I will say that there are one of the problems with an occluded stent is more that you develop all of these collaterals around an occluded stent, and this was a high jugular stent that had about 35 little tiny collaterals coming around it and coming down. So when I went to try and recanalize the stent, I just couldn't find my way back to the bottom of the stent. And that became a big problem. So that's going to happen, and it's going to be unavoidable. On the other hand, the same patient had a stent on the other side that looks pristine. So why did the stent on the left side occlude, and why did the stent on the right side look pristine? This is the kind of thing that confounds us as interventionalists every day. We don't know enough about individual patients' restenosis response and genetics to be able to figure out why one thing does one and one thing does the other. This is just a picture of what Justin was talking about, and this is a stent that is filled with restenotic tissue. And you can imagine once that has grown all the way in and has sat there for 6 months, it's going to be pretty hard to get through there and do anything to open that up and make it look good. On the other hand, this is the difference between an undrug-coated stent in the coronary arteries and a drug-coated stent in the coronary arteries that had a drug on it to inhibit restenosis that works and has worked remarkably well in the coronary arteries. Unfortunately, the largest diameter stent available on the market that has those drugs on it is about 3.5 millimeters and is pretty useless in the setting of CCSVI. One place that I've done a lot of work and we know a lot about is arterial interventions in the legs, and there are a myriad of techniques that have been done. And what it turns out is that there's a lot of restenosis out to 2 years despite all of those techniques, though we're getting closer. And this is what restenosis looks like in the leg artery. The entire stent has tissue growing throughout the stent all the way along it. And that tissue can be pretty hard to deal with. But there are drug-coated stents now coming out for the leg arteries that show a significant improvement. Maybe at some point that will be something we'll want to use in CCSVI, but we don't know because veins are entirely different. There's whether self-expanding metal stents that were designed for the biliary tree and arteries, both tubes that have muscular walls that are relatively similar in size all the time. They don't go from 5 millimeters to 18 millimeters when you sit down or stand up. Whether those stents will work well in those veins, we just don't know. And that's part of why we try not to use them if we can. So I sort of disagree with some of the things I've been seeing lately, that these stents were designed for veins. Most of the data on dialysis when these stents were used in veins showed no benefit in patency in most trials over plain old balloon angioplasty. Stent grafts have shown a benefit in one trial, but that was a marginal benefit. So what about the safety of the CCSVI procedure? Well, I guess we've pretty much beaten a dead horse here. This was presented at the SIR meeting, 247 procedures, and they had very low rates of significant complications. One stress-induced cardiomyopathy and a few arrhythmias. And I think if one's careful, the arrhythmias can generally be avoided. So I think what we do have enough data now to say that angioplasty and selective stent placement is relatively safe. Don went through our data, and we've had that one minor adverse event. However, people were asking, well, what other adverse events are out there, and what do we don't know about those 15,000 patients? Well, through the grapevine, you hear about things, and there are other serious complications that have occurred. People have had intracranial hemorrhages. People have had strokes. I've heard about these cases. So I would say that we need to be honest about the fact that we don't know about what's happening with those 15,000 patients, and people need to be careful about where they go and get these things done. So I'm not going to talk about our technique anymore because Dr. Gooding covered that rather thoroughly. I will show a case that I thought was interesting that shows you can't really predict when you're going to have problems. This is a patient that I treated who had a relatively normal-looking right internal jugular vein, but the MR was very abnormal. So we now treat those valve sites when the MR flow rates are very slow based on the MR, and we combine that information to help us decide when to treat. I think if I put IVUS up here, I might have seen something at that valve site that I can't see with a venogram. This is the other jugular vein, which was markedly abnormal. And you can see on this other jugular vein that it's very small up here. I thought there was a stenosis here, and there's no flow in the distal internal jugular vein through the valve site whatsoever. So I dilated both of those and got a pretty darn good result. And then this is pre and post, so you can see how much this vein has gotten bigger after you treat it. And this was the azygos vein in the same patient with multiple valve sites throughout the azygos vein. But down here, it looked like what Dr. Gooding was talking about. This looked for all the world to me like extrinsic compression. So I dilated the valve sites, I dilated the extrinsic compression, and it looked better. We still had this area that looked like extrinsic compression, but there was better flow through the azygos vein in general. This is when the patient came back with restenosis several months later. You can see that the upper jugular vein, we've got these collaterals filling again. The upper jugular vein is just sort of diffusely small, doesn't look bad. And I've really, at this point, changed my technique to treating the lower jugular vein first. We've learned that, really that valve site, if you open that up, you get a better look at what's going on upstream. You know better about what the collaterals situation is. So I treated the lower jugular vein, and now we're using slightly larger balloons at times, being a little bit more aggressive, and you can see that it looks a lot better after that. And I went back to the azygos, and I treated this with an 8mm diameter balloon before. The valve site looked a little restenotic, not too bad. There was collateral flow, and there's this extrinsic compression again. So I said, well, I'll just dilate that whole area with an 8mm balloon again. This is a rupture of the distal azygos vein that I had previously treated with an 8mm diameter balloon. Now, luckily, this is in the distal azygos vein, sort of down in the posterior mediastinum. The patient really didn't have any pain. She didn't even notice. I was able to recanalize that, sort of do a prolonged balloon inflation, and lo and behold, I've got a little tear in the vein here, but it looks better than it ever looked. So something I thought was extrinsic compression actually turned out to be an intrinsic lesion. And that's where we are having problems. So, I'm showing you my problems. And so it's very hard to standardize how we're going to treat these things. Did I need to treat that low azygos stenosis? Did I have a complication that mattered? The patient did fine. Didn't turn hair. Didn't significantly bleed. And you can see it was almost, I watched it for 15 minutes, and you can see it sort of starting to look like it did before treatment, but she's doing fine. So I'm going to end with that just to sort of say we still have a lot to learn. What I would conclude is it is not simple to determine what the best practices are in CCSVI. It's extremely complicated, more complicated than a lot of the things that I've dealt with before. Operator experience and caution is sort of critical to safe treatment, and I would beware of claims of outstanding or better results on the web. Because I think business considerations are starting to take over a little bit here, and that kind of bothers me. We'll just end, because gas prices are so high, with a couple of jokes to make everybody happy. This is what it takes to get gas now. Please insert your credit card. Please wait. Enter the make and model of your car, followed by your annual salary. Please wait. Your loan has been approved.